things off by introducing everyone to Sarah Weta-Pole from the Community Foundation for Southeast Michigan. And Sarah came to this panel vis-a-vis Washtenaw FAN board member who said that when she heard about this panel discussion, she mentioned that Sarah's organization was acting somewhat like a liaison between the state of Michigan that provided the funding for much of the work that you're going to hear about here and these hospital systems. So Sarah, with that, why don't you go ahead and talk to us briefly about how you interact with these hospital systems and how the funding came to be.
Great, thank you. And thank you so much for inviting us to speak. I represent a bunch of people. I'm just the representative on this call. And it's wonderful to see all the hospitals joining today. So thank you. I can start by, I don't know if I can show my slides here, and I think if I could see them. Thank you. But I'll start by saying that we are basically called in name the Michigan Opioid Partnership. And really what that is about is philanthropy at its best will try to leverage state funding. So of course, philanthropy is about giving money out to the community where there is a community need. Government, of course, is trying to also support communities. So what we do is look for ways to supplement or leverage public funding. And with a large amount of money coming in nationally to address opioid use disorder and overdose instances, then it was really important that we work very closely with state government to make sure that we weren't duplicating or filling in needs that could be gaps that are already filled by state government money. So we have to work really closely with the state in that sense. So when we talk about a public-private collaborative, we are a bunch of foundations working together with the state to make sure we can cover what is needed in order to fund programs that are going to be the best practice for the community. So next slide, please. So I always showed this slide to show who we are. So we're the Community Foundation for Southeast Michigan. We are the holder of the funds. So what happens is basically these other foundations you're seeing on the screen, as well as like Blue Cross, which is obviously not a foundation, but contributes to the effort as well, puts money. And then we as a community foundation, which is very common with community foundations and also with United Ways, we hold funds, and those funds then can be granted out. So we're both taking in money and we're giving it out. And that's something that the Community Foundation can do. So we decided we were going to be the home for the partnership. And what happened was there was a large amount of money coming in, as you all know, it's called state opioid response money. It was nationally distributed, billions of dollars. And so the state obviously got some of that. So in order to make this work well, the Michigan Department of Health and Human Services said, all right, we're going to leverage some of the philanthropy dollars and put in a large amount of money that then you can work to distribute. So where did we put it? Next slide, thank you. I appreciate you running the slides for me. So where do we put it? So we knew we wanted to align. The governor said that she wanted to reduce opioid overdose by 50% in 5 years. So we knew that was something that was important. And because many of the foundations that you saw on the screen previous are statewide, it's really important that they're always aligning with the state. We also wanted to increase access to evidence-based treatment. So you'll hear from these brilliant hospital staff that are working really hard to bring evidence-based treatment. And in this case, it was very specific. SAMHSA, or the national funder, said, we know that medication is really key to helping reduce instances of overdose and helping with opioid use disorder. So we tend to call it MOUD, some medication for opioid use disorder. Some people will call it MAT. So we knew this was a priority. And we knew that hospitals were really interested in focusing on this. So we thought, where are people coming the most when they're actively seeking help? And it tends to be emergency departments and jails, just because of the way that the process works. We know that many people who are incarcerated also will have an opioid use disorder. So we decided we were going to focus on that. And what did we do? We went to different states that have already implemented this statewide. So if you look at Massachusetts, Mass General is a massive hospital system. They have implemented a protocol that really works with people when they come in with any kind of addiction or overdose. We went out and visited them. We worked with them to get their best practices. And then you look at California, that has an amazing program that works with over 200 hospitals in their state that said, you know, this is working well. We have what it takes to be able to help patients and help people walking through those doors. And we had partners in Michigan who are on this call today who were really ready. And those were really physicians and other hospital staff who said, we see this every day. We see people walking in our doors and we see how we're not treating them the way that we could. And so it created a big shift and a groundswell with hospital staff really from the bottom, not necessarily the CEOs, though some cases there were, but really those physicians who are seeing, and other staff too, pharmacists, social work, not just physicians. So that was a really big priority. And another big priority, obviously, is racial disparities. So we know that for Black and Brown people, the rate of opioid use disorder and deaths have gone up, whereas the state, it's varied. So it depends on the statistics, but it's more stable. And so we know that there are racial disparities in some of our big cities. People are not offered medication as much as they are when they're not in the big cities. So it depends. But you also have the UP and some rural areas that also have great disparities. So it's really a big issue no matter what community you're in, but knowing that race is a factor in this, it's really important that we address this. So we're looking at that specifically across all of our work. And then lastly, we can't address enough, even though our grants are specifically for medication for hospitals, to help them implement programs that work for them, but also to reduce harm and also support recovery. So that means we are helping to create a system where hospitals can really provide that warm handoff, meaning they're not just going to give you a piece of paper saying, please go to this, call this number, but really have a relationship with the providers in the community. And there are wonderful people who are right in your county, like U of M, the Michigan Opioid Collaborative, does an excellent job linking outpatient providers to hospitals. So it's been wonderful to watch them and work with them best we can. And then last slide, you're gonna see this throughout, you're gonna see this theme throughout the talks, I'm sure, as our hospitals speak. But this slide hopefully demonstrates kind of what we have seen hospitals be able to do when they really pay attention to when they listen to the community. And that's really around not only medication for opioid use disorder, that's one thing, but it's also stigma and its connections to the community. Because if you don't have a place to go once you walk out of those hospital doors, you're going to come back to the hospital for treatment. And our physicians have taught us so much about what it means to be a patient when you walk through the doors of an emergency department. It's really incredible. So we are the facilitator of the funds, but we also try very hard to support with technical assistance. We have physicians who have helped us. Many of them are on this call today in this meeting. And we also have community members who've helped guide the work as well. So I'm glad to answer any questions, but really the people who you're going to hear from are the true experts. We're just the facilitators of trying to work to change the system overall and link everybody together.
So Sarah, even though stigma wasn't a part of the initial funding, the hospital systems have kind of taken it upon themselves to identify that as a barrier to care, and they're, educating staff and everyone so that when a patient comes in asking for help, it's a little bit different than it was maybe 10 or 20 years ago, correct? Yeah. Okay, so they've taken the ball and run with it as it pertains to stigma in many instances. And before we get into, we're going to start with Hurley, the Hurley healthcare system. with Dr. Reese and Dr. Bolton. For those of you who are joining us, the takeaway here, if you have a family member who is struggling with the disease, or if you are in fact struggling with the disease, take notes, okay? And learn, because things are changing. And what was very gratifying for me to learn when I talked with all these amazing people on Friday was that they're setting the bar high and things are going to be different. So when you're listening to this, if you know someone who is struggling, who needs help, this is what they're going to experience when they go ask for help at any one of these regional healthcare providers. With that, I want to turn it over to Dr. Ryan Reese and Dr. Molly Bolton from the Hurley Medical Healthcare System. You guys go ahead.
Thank you.
Dr. Reese, did you want your PowerPoint up now, or you just let Brandon know whenever?
Yeah, let's put it up. Yeah, we can get that up now. And we can talk about what we're doing up at Hurley. So as Mario said, Ryan Reese, one of the ER doctors at Hurley. I'm working closely with Molly Bolton, one of my partners in the emergency department, as we are working on expanding MOUD at Hurley. We are a partnership of both the Hurley Medical Center and Michigan Medicine. All the ER doctors up there are on faculty at the medical school there and in the Department of Emergency Medicine. Brandon, go ahead and go to the next slide. And so what we're doing now, or what we've been doing for the last couple of years for OUD in the emergency department, first and foremost, it's very much a collaborative effort. It's very difficult to do anything on your own, and we rely heavily on our social work staff in the emergency department, helping with conversations, helping with linking patients to resources. And we have some great recovery partners in the community who we've listed here as the New Paths, and they have a program, the opiate overdose response program. They send out recovery coaches to the emergency department to link with patients and get them into recovery, get them into their programs, and just be having different conversations than myself or Dr. Bolton could have. Things we're doing now, and I believe Dr. Bolton will chat on here in a little bit, are our naloxone kits. We have another slide for that, which we'll talk about. And then something we've been doing the last couple of years as well is buprenorphine induction in the emergency department. So the most common brand name is like Suboxone, which is a buprenorphine and a naloxone combination medication. And so patients that come in with opiate withdrawal symptoms, they're looking for help. We have a plan in place to get people on a buprenorphine product, either via what's called the 3-day rule, meaning patient gets treated one day, and you come back the next day and the next day and get a dose every time, or as the regulations have been tweaked a little bit recently, it's easier to get an X waiver, and so your doctor can now prescribe this medication for you in the community instead of coming back to the ER every day for the next couple of days. And so that's something that we've been doing. It's something we're very proud of. And then go to the next slide. Dr. Bolton, I think we're going to talk about some other work we've been doing.
So this is primarily a slide to kind of toot our own horn a little bit in terms of our work towards harm reduction. We have been working with the Michigan Opioid Prescribing Engagement Network, Open, for the last couple of years to distribute naloxone kits directly from the emergency department. So not requiring patients, we used to require them, they would have to go to either a pharmacy and fill a prescription, or they would have to go to a local community center to pick up a kit. And now we have them in the emergency department. They are of no cost to the patient. They are not billed through their insurance, and they leave with the kit, with gloves, with a QR code about how to use them. They are educated on how to use the naloxone spray. And so they walk out with the kit ready to use, either, for themselves or for someone else. And so this is overall through the M-Open program, the kits that have been distributed since the start of the program, over 1,300 kits. And then Hurley here, we have given out 257 kits. So we give out right around 15 to 20 kits a month. Right now, they're targeted to people who come in specifically with overdose or with people who have a known opioid use disorder in the past. But we are trying to expand that to people who are on chronic opiates, who might be at risk for accidental overdose, and other patients who may be at risk. So we're working to increase our distribution of these kits, because that's one way we can work towards harm reduction. And I think something that I've noticed since initiating this program is I think it has helped reduce the stigma in our department. I think people are starting to see this as a medical problem, something that we can help treat, and ways that we can help our patients. So this is something that we've been doing, and actually been doing really well. And then I know Dr. Reese is probably going to speak a little bit more. Our medication assisted treatment program is kind of in its infancy currently, but we have big plans and are hoping to really make a difference for our patients going forward in that realm. But we have been giving out or treating patients with Suboxone from the emergency department, and many of our providers are providing prescriptions from the emergency department, and then they are linked directly to recovery systems and follow-up care through the OORP program that Dr. Reese mentioned. So I think we've really had an expansion in our services and offerings in the last probably 24 months at Hurley, and like to think that we're making a difference, although I don't know that we have a lot of hard data to support that at this point.
Is that it, Dr. Reese and Dr.?
One more, last one.
Okay, go ahead.
Was one more. This is what we're excited about. This is what we've been working with Sarah's team at the Community Foundation for Southeast Michigan, and this is what the next step is for Hurley and our expansion on MOUD. So I'll try to be brief, because I know we're on a bit of a time crunch. We're doing a couple things. We are tweaking how we do the triage process. As Dr. Bolton mentioned, stigma. We need to make specifically OUD a medical problem that it is. So asking people, you have some blood pressure issues, you have maybe some diabetes, and you have OUD. Okay, no big deal, right? So patients disclose or asked if they use opiates. It triggers a social work consult. It drops on a list that we at Hurley follow up, and we're reaching out to patients and engaging with them and getting them into treatment. We're getting better in how we document OUD, more for public health and for tracking reasons, because we don't know how well or how not well we're doing this. So being diligent on how we document opioid use disorder, the ED culture. So patient-facing posters and pamphlets, we need so this type of stuff is helpful. But once people are in the waiting room, they have a program that can help me out. Maybe it might spur a conversation like, I saw that you guys offer naloxone, or you offer these kits. Hey, I think I know someone that might help. So patient-facing signage, posters, pamphlets, all sorts of stuff to let the community know what we're doing. We're working with our community recovery program in getting CME, continuing education for our ER doctors, nursing, social work, any ER nurses, and training them on screening tools for substance use, addiction 101, like what is it, what it isn't. Talking about motivational interviewing specifically for providers and trying to engage them in conversation, working on stigma bias, bringing in recovery coaches, hearing about folks that are in recovery, and that there is a light at the end of the tunnel. Sometimes in the emergency setting, we don't always see those types of things, and those types of we don't find out about those types of things. And so hearing about cases that went well, or people that are doing well in recovery, and kind of giving a different perspective on the on recovery. I'm going to be harassing my ER doctors and other prescribers, if they don't already, get their X waiver. And if they have their X waiver, it's time to use it. And the last piece that I'm the most excited about is we're going to have a bridge clinic, buprenorphine bridge clinic at Hurley. We're going to leverage our virtual capabilities to keep people sustained in treatment. We're going to be following these people up, making sure they're in treatment, doing well. And this is a bridge between the emergency setting and getting folks into into definitive care. And there's a lot of negativity with pandemic and COVID and whatnot, but the virtual medicine and what we can accomplish on telemedicine has been something that we've noticed, or that we've in medicine have noticed that we can do better with. And this is the one thing that I'm the most proud of, and I'm excited to see how this looks coming up later this year.
Dr. Reese, you should be proud of all of this. This is incredible work. And for those of you who are joining us perhaps for the first time, you're going to hear the term peer recovery coach used often. And just in case you don't know what that means, I'm pretty sure that most of the people Zooming in are aware of it. But for those who aren't, that's simply someone who Hurley and some of these other healthcare providers are going to put in touch with your loved one or with you who have been right where you are now. They were battling an addiction. They've, are a part of the community that you share, and they've come out on top, and they're sharing their story and their successes and advice. And I know that we believe at FAN in peer recovery coaches and family recovery coaches. So I just wanted to let everyone know that you're going to hear that term a lot. Doctors Reese and Bolton, did that conclude your prezo?
Yes, there were some questions. I don't know if you wanted that answered on the video or.
We'll address those at the tail end, okay? And for those panelists who remain, let's try to keep it to 5 or 6 minutes per, okay? And we're going to move on to Dr. Michael Gratson from the Beaumont Healthcare System. Hey, Dr. Gratson.
Hi, Mario. And I just want to say thank you for putting this presentation together. This webinar is really great. And this is my first time attending one of these FAN conferences, but I'm just so excited to be here and hear about all the really great work that everyone's doing. So yeah, so this is really fantastic. So I do have a couple of slides I'm going to share, but I'll read them a bit. I'll mostly probably just talk off the cuff to you guys because that's how I like to do things. But I'm from the Beaumont, and I'm an emergency physician, and I'm also the medical director of our medications for opioid use disorder program, which we recently started just a little bit over a year ago. So this was a project that thankfully we were able to put together really due to the support that we received from the Community Foundation. So I want to also extend my gratitude to them that they helped us to just give us the resources and what we need to get this off the ground. So to tell a bit of a personal side of things here, I've been an emergency physician for about 10 years. And one of the things that always really frustrated me as a provider was when I would see patients that were in withdrawal, or if they were just after an overdose, I always felt like we we didn't do much. It was really very frustrating because I wanted to help these people, but I just felt like we didn't have the infrastructure, we didn't have the tools needed. And at the end of the day, it would just always felt like, God, we got to do more, you know. And that's kind of and there was one patient in particular that just, it really turned things for me and really made me say, all right, I got to get off my butt and start doing something about this. A gentleman actually drove down from about 2 hours from the thumb. He had opioid use disorder and was just in the throes of withdrawal, and it was really harming his life in a number of different ways. And he came to our emergency department and he said, Dr. Gratson, I'm here to see you because I know Beaumont's really great and you guys are going to help me. And I gave him a number. I didn't have my X waiver at the time. I felt so restrained and I felt so bad about the job that I did for this gentleman. And I felt so just, this is not right. And it was probably about a week after that, we really started leaning into this and said, we got to really revamp what we're doing here, because that can't happen again. We can't have somebody who's desperate for help and say, here's a number to call. It's not appropriate. It's not good care. If somebody came to me with diabetes and said, Dr. Gratz, my blood sugar is too high, and he said, here, call this number, I should hang up my license. Like I shouldn't be practicing medicine. And that's how I feel about opioid use disorder. We really need to advance, how we're treating these patients. So it was just like, I felt like I got hit on the head with a hammer, that we needed to do better. And fortunately, with the help that we received from community foundations, from just, all these other health systems at large here as well, it helped guide us to really kind of get our butts in gear and to get things into a better situation. So I wanted to talk about what we are doing. Thankfully I started out with our failures, so can only get better from here, right? So I'm going to talk about our successes. So about a year ago, we really leaned into making sure that we were providing evidence-based care for patients with opioid use disorder, when previously we really were not at all providing evidence-based care. So we looked at, what were other hospitals doing, what was recommended from SAMHSA. And, we landed on the SBIRT model, which is screening, brief intervention, and referral to treatment. So very quickly, we said, you know what, we're not going to be able to help these people if we can't identify them. So we created a process in which we screen all adult patients that come to the emergency department. We need to provide meaningful interventions for them. This is our opportunity. If somebody comes in, for an overdose and withdrawal, if they come in for an ankle sprain and they have opioid use disorder, this is our opportunity to create a meaningful intervention that we can really try to help these patients. And that's what we really wanted to do. So we really worked hard to get our physicians X-waiver certified. We created protocols to be able to initiate people on Suboxone. We could even do home inductions for them. If, in the emergency department wasn't the right time to start it, we could send them home with the medication, as well as a pretty easy to follow home induction. And then we created something we call our STAR team. And we really felt like that was an appropriate term for them, because they are the stars of our emergency department. They're helping the patients that really need it most. And yes, we did come up with the name first, and then we worked it back to it standing for Streamlining Treatment for Addiction Recovery. But we started with STAR and then we worked from there. And we also really felt that it was important that we really do create good, strong partnerships with outpatient recovery programs in the community. And we really wanted to vet these programs as well. We wanted to make sure we believe in evidence-based medicine for these patients. We want to make sure that they do as well, because if we're going to entrust our patients that we're going to take care of in the community to these outpatient recovery programs, we want to make sure that they're going to provide the best level of care as well. They have to meet our standards. So we did some rigorous vetting. We found good partners that fortunately can see our patients generally within about 72 hours after our emergency visit. So we really wanted to make sure we could get them in quick. And we'll help them out in that time, in between, and be that bridge over troubled waters for them. But we needed to make sure that we had this good partners there. So this is kind of how our flow works, right? So kind of an operations guy at heart. So I always like to kind of put these out in diagrams. But, it just basically, our patients go to rooms, they get screened. If they screen positive, we have a process that alerts our providers that this is somebody who's screened positive for opioid use disorder. We get a consultant to our STAR team. If they're present, they do bedside assessments and really perform warm handoffs for these patients. If they're not present and, say it's 3 a.m. and you come in, we created a process that our team could actually do a a televisit the following morning. So they'll reach out to that patient. If they're able to go home and they want to go home, we'll reach out to them and really just try to break down whatever barriers we can to get them into treatment. You know, our STAR team here, I'll put up some pictures. This is a version of me with significantly less hair on my face. But this is our peer recovery coach. We have a social worker. We've got a PA who assists with us. And then we've also got a care coordinator. So we really kind of take this, this team approach to these patients and wanted to make sure that we're providing meaningful interventions with them. Mario, I know you brought up stigma several times as something that's just really critical to talk about. Thank you for bringing that up, because that's something where pretty early on, we found out that if we were going to do a better job taking care of these patients, we must address stigma. That is something that, it limits us and our ability to provide that appropriate empathetic type of care that these patients deserve. But also too, we need to work on not only stigma within our staff, but internalized stigma that patients feel. Very frequently, they get messages from in media and society from previous medical visits that they've had, where they see themselves as, not necessarily deserving of excellent care, of the, appropriate, treatment for to really help them. So we really have been working on that, particularly in the last 6 months. We created a program where we have different marketing materials, signage, pamphlets, posters, things that to really help kind of call patients to action, that just help them identify themselves, let them know that we are here, we care about them, we really want to intervene in a meaningful way to really help them toward recovery. And we also provided, we just recently last month, we had a guest speaker come in who's a PhD in cognitive behavioral philosophy to just talk to some of our providers and staff and help to train us on, how do we identify stigma better? How do we identify it within ourselves? How do we confront stigma when we see it? And how do we, utilize that to really try to, create a place of change in the emergency department where we can better, help these patients, make them feel more welcome. And like I said before, I had this, unfortunately, I really failed as an emergency physician before we started this process. We really want to try to just eliminate those types of visits where somebody comes asking for help and we do very little for them. And that's really important. The stigma is a key part that we must address on that. And we are actively working at that and moving it forward to really try to, reduce that as much as we are physically able to. So I will stop sharing my slides there, and I'll look forward to any questions that you guys have.
So remember, we're taking questions at the tail end. Thank you, Dr. Gratz. And there's obviously a whole lot of good things happening within the Beaumont system. Thank you for all you're doing. For those of you who might be wondering, I've had several people email me who couldn't make it. This is being recorded. It's being streamed live on Facebook. We're going to post this on our YouTube channel. We're going to put it on our website. So if you know anyone that wants to learn more about the subject we're discussing, all they have to do is watch the recording of the meeting. With that, I'm going to turn it over to Dr. Weiner from IHA and the St. Joe Mercy Healthcare System. Dr. Weiner?
Hey, Mario, thank you for inviting me. And I have to say, sitting here, I am just moved by what is going on and the passion that's out there. We all live in our little hospital worlds. We don't know what other people are doing. And just hearing what other people are doing is just amazing. And so I'm Mark Weiner. I'm the medical director of substance use disorders at St. Joseph Mercy Hospital, Ann Arbor, section head of addiction medicine. I'm also the program director of the Addiction Medicine Fellowship at St. Joe, which is the only addiction medicine fellowship in the state. We'll talk about that in a second. But just what we do, I'm going to gloss over some things that are kind of repetitive, what other people are doing. We began a mission of holding a symposium every few years to teach the public about addiction, to teach professionals about addiction. It's been on hold due to COVID, but we focused on, the neurobiology of addiction, treatment in various special populations, pregnant patients, elderly, adolescents. And we talked a lot about the management of pain in addiction and pain and addiction, because that is a very huge issue for many practitioners out there. It causes a lot of anxiety and difficulty, and we're sort of the voice of reason often in those difficult conversations with patients and with other doctors. Our emergency room is also involved in something similar that's been presented. We have a federal grant to assess patients with opiate use disorder, and especially those revived after an overdose. When appropriate, begin them on MAT with buprenorphine, and our ER works directly with our fairly large addiction medicine clinic so that patients can be seen within 72 hours in our clinic, guaranteed, so that there is this continuity of care and patients aren't just given medication and cab fare and then, you know, who knows what's going to happen. It probably isn't going to be anything good, except they're going to come back hopefully later on. In addition, like I said, we do have an addiction medicine fellowship as part of our institution. So we have right now 2 fellows in the addiction medicine program, and I'm the program director. This creates a place for any doctor of any specialty in our hospital health system to contact us to get direction when treating patients with substance use disorder. We go to all parts of the hospital: medicine, floors, surgery, OBGYN. And we hope that these future expert addiction specialists, fellowship trained addiction specialists, will go on not only to learn themselves about addiction, but teach hundreds or maybe even thousands of other people in the healthcare community and in the community in general about addiction from an evidence-based standpoint. As an invitation to the other healthcare systems, if you would like to talk to me about us expanding our fellowship to include your hospital, please let me know. We just included St. Mary's with another fellow. One thing that we have been doing that I think is rather outstanding and I'm very proud of, we've probably had the only in-house addiction medicine consult service going on for about 25 years at St. Joe. So basically, anyone anywhere in the hospital can get an addiction medicine consult for whatever reason that they're admitted to the hospital. One of my colleagues or myself will see that patient, do an assessment, provide guidance for care. If MAT or MOUD is needed, we'll initiate that. And what I think is really special is one of us will actually see that patient in the outpatient clinic in 3 days. So they'll be meeting their doctor while they're in the hospital bed and following up with the same doctor a few days later. That continuity, I think, is really important because, as other people have mentioned, we lose people in that transition from, even if we identify them in the hospital, we lose them in that transition to the next step. So we hope to retain them, and we're doing a pretty good job at doing that. There was a question that came through, and I just want to, why do we get tons of referrals? How do we get so many referrals in our hospital? Because we do universal screening for SUD on admission. So everybody gets some initial questions, which triggers a social work consult if needed, and then later on an addiction medicine consult if we're needed even further. Again, just to point out something that we do sort of, I think, a little bit special is that education integration, again, with pain and addiction. There's a lot of anxiety about the use of opiates, which can put people in chronic pain in a serious situation, but also there's a lack of understanding and identification of addiction. And many people who end up having addiction severe enough to cause problems and end up in the hospital did start with a prescribed opiate. And so early identification of when things go awry is very, very important. So we work closely with high-risk patients so that when they are treated with pain for trauma or some other issue, that they are also following with an addiction doc in our clinic within that first week, so that there's 2 people looking at it, one an addiction specialist, and of course, whoever is required to manage the trauma or injury or surgery. Additionally, in our addiction medicine clinic, we do universal screening to see who needs naloxone rescue. We also do bloodborne pathogen screening, and we actually share physical space with our infectious disease colleagues. So there's a warm handoff for patients with bloodborne pathogen, HIV, and hepatitis to our ID colleague. And we work together to treat that patient. They have one place to go to get all those two things met. We work very closely with our in-house treatment program, Greenbrook Recovery Center, which provides IOP and counseling. It is directed primarily not just to robust SUD treatment, but dual diagnosis treatment as well. And we work very closely with Dawn Farm Home Division, which are some bigger treatment programs in our area. We found out through COVID that we can provide a lot of care virtually. So some of our patients now are 200 or more miles away. Some live in the UP, and we've worked out ways to have them be screened on a regular basis and treated appropriately so we don't lose them. It is hard to get care up north for addiction if you don't know that. And just finally about stigma. We run into stigma all the time. We all do, all of us here on the panel. It is a real serious problem. It is ingrained in not only healthcare providers, but the insurance companies, the community in general, some employers, patients themselves. The stigma is created within the patient themselves. And that needs to be addressed and normalized. And there are a lot of ways to do that. We do a lot of education, and we are very open, I believe, to meeting people where they are in their recovery and telling them that it's okay, and we'll take them to the next step. Hopefully, I believe with doctors, there's education is a major part. I believe in all healthcare providers, there is that compassion is there, but it's hidden at times due to fear and anxiety and a lack of understanding. And I think that through education and just being available to talk to other providers, we can have them reaccess that compassion, which is going to be so necessary. So I don't want to take any more time, and I will take questions at the end. That is the end of my off-the-cuff presentation. Thank you.
Thank you, Dr. Weiner. And I know the St. Joe system has been at this, you mentioned it, for many years. So thank you for leading the pack in that regard. We appreciate all you guys are doing. And your place is right in our community here in Ypsilanti. So thank you for all you do. Okay. Emily McCall and Dr. Menke. Michigan Medicine is up with all that's going on there in Ann Arbor.
Absolutely. Thank you so much for having us. My name is Emily McCall. I am a social worker with our ACT service. That is our addiction consult team. We prefer to go by ACT. We want to make sure we're being inclusive of all our patients, not just those who self-identify as having a substance use disorder. I'm going to let Dr. Menke introduce himself.
Hello, I'm Nate Menke. I'm a physician, board certified in addiction medicine, emergency medicine, and medical toxicology. And I came to the addiction field pretty similar to these other providers. There was a huge patient population with their needs being unmet, and it was very difficult just watching these patients come back over and over without adequate treatment. And that's what got me to the field. And what's kept me in the field is working on an amazing team. I'm just one portion of this team. We have an amazing social worker, Emily, who you'll hear from. We have a peer recovery coach. We have a nurse. We have a pharmacist. It's just, we're all working together to try and take care of these patients. And that's a very rewarding portion of my job.
Well, I will take it back over. I just want to give an overview of the services we have and what we're doing for our patients at Michigan Medicine. So this has been a work in progress for quite a while, and we are so excited that we were finally able to launch this service starting in April. So in April, it was myself with a little bit of pharmacy time. We started with the emergency department, really looking at where we could support our patients there. In May, we added Michelle Browninger, who I know is here. She's our wonderful peer recovery coach. And then in June, Dr. Menke joined us. So this is all pretty new, but I think we've been jumping right in, and we all love what we do, and that makes this job so enjoyable. It's not easy work. We know so often our health system works against our patients with substance use disorder that it can be a stigmatizing, challenging place to be. So to be surrounded by people who are so passionate about this work, both in our system and locally, is incredible. So we support our patients all across the hospital. We support our adult and children's emergency room. We support our adult children's hospitals, our cardiovascular hospitals. I think we got more than all our steps in today running from Children's Hospital over to the cardiovascular and everything in between. So that's another perk of what we get to do. And it's just been an incredible opportunity. We get to see our patients who come in, not just with their primary issue being their substance use, but we get the opportunity to work with our patients that are coming in for a variety of different medical concerns that may or may not be related to their substance use. Sometimes it just happens to be something that gets brought up and we have the opportunity to address it. Sometimes it's the complications of many, many years of substance use, whether that's infections or skin issues or a variety of different things. Again, we've not been at this too long, but we've had the opportunity to build great relationships with the teams in our hospital. They call on us again, not just for our opioid patients, but some of this pain, opioid gray area, alcohol use, stimulant use. We've seen a lot of everything across our system. We know this can be a population that not everyone is comfortable with. So not only do we get to do the clinical work at the hospital, we have the opportunity to educate others on what is evidence-based care for substance use. How do we manage pain in a patient with a history of opioid use disorder? And to me, that's just as important as the clinical work we do. It's awesome to be able to work directly with patients, but it's also awesome to help empower other providers in our system to feel more confident in this work. We had residents with us. We had our very first starting 2 weeks ago, and just the opportunity to help our future physicians normalize this care so that it becomes routine for them has been an incredible opportunity. I'm just so excited to be part of this, and that's me in a nutshell. I'm sorry for just rambling. Feel free, Dr. Menke, to add anything in if I missed it.
Dr. Menke, did you want to add anything?
I just want to emphasize what Emily was saying, that most residents get very, very little training through medical school and residency regarding addiction care. They may get like a day sometime during their training. So we are providing that, not only to the patient, not only to the physicians who rotate with us, but the ones we interact with on the floor. So that's been a huge part of our service, is just education.
And then I want to jump back in if that's okay, Mario. So
Sure, go ahead.
I also wanted to mention our consult service. A lot of times consult teams stop when the patient leaves the hospital, but we have the opportunity to continue to follow our patients as they transition into the next level of care. We worked really hard with our own primary care clinics to be able to keep some of those patients within Michigan Medicine and to take care of our patients that are already getting primary care at Michigan Medicine. So we have almost all of our primary care clinics are doing buprenorphine or Suboxone treatment, which is super exciting. That's a significant increase from where we were pre-pandemic. So we have that, and we have our wonderful nurse navigator who follows the patients in the primary care side of things. Michelle and I follow and keep in touch with our patients who are going out into the community. We're very grateful for our community partners, not just in Southeast Michigan, but really across the state. Patients come from all over to get their care at Michigan Medicine, and we do everything we can to connect them, whether it's Michigan or even out of Michigan. I'm not as familiar with those resources, but we're always willing to do whatever we need to do for our patients. So like I think it was Dr. Bolton mentioned that, or someone mentioned that not just during business hours, our patients come in at all hours of the day, but we're only here during business hours. So we work closely with the emergency department and their social workers. So we have really great collaboration so that regardless of what time of day a patient is coming in, because we know a crisis doesn't only happen between 8 and 4, that these patients are getting follow through and we're able to touch base and make sure they make it to that next level of care safely.
Yeah, and you know, you mentioned the follow-up that you're providing, and I'm hearing that as a constant, as a continuous theme. That follow-up, for those of you who are participating, is critically important in terms of a recovery. You know, if it's just a we'll see you later kind of thing, it doesn't work. There's evidence to support that. So Emily, thank you for chiming back in and adding that. Others have added that. One other thing I wanted to make note of before I turn it over to Dr. Yanga from Ascension is Emily and everyone so far has used the term patient to describe people that are coming in looking to get care, not addict. And thank you everyone for that. It's part of the destigmatization of the disease. They are patients. They are patients like your diabetics you're treating, like your CHF patients, like your Parkinson's patients whose med might be off and needs an adjustment. You'd make a consult to your neurologist. What's so gratifying is you're seeing the normalization of the disease. And thanks, everyone. So with that, Dr. Yanga from Ascension, you've got a lot of interesting and exciting things happening, not only at Ascension, but where you reside at the Brighton Center for Recovery.
Yeah, thank you. And thank you for bringing us all together. Again, extremely inspiring to hear what is happening broadly throughout our state as what is a movement. And so very inspiring. So I am the Chief Medical Officer of Ascension Brighton Center for Recovery. And so we've been delivering care for our patients here in Michigan. We're the second oldest ongoing treatment facility in the country. And so we provide a full range of services on our campus, which is not an acute medical center campus, from detoxification services, inpatient rehab, all the way down to longitudinal outpatient services and the health professional recovery program services as well to serve our healthcare professionals in the longitudinal model. So as far as the delivery and focus is on the services that we provide at Brighton, there is definitely a focus on really working on the cognition impairment of the brain. Certainly this disease, any substance use disorder, has profound impacts on brain health, and the cognition science field has demonstrated a lot of what those cognition defects are, which do have impacts as to how patients engage in therapy, as well as adherence to treatment through longitudinal programs as well. So it does take time, and it does take a longitudinal approach and connections with people through time, which is what you're hearing as a common theme is for any strategy to work long-term for our patients, it has to be continuous, and it has to be taking into account the medical side, the psychiatric side, our therapy services, but also really replenishing the brain and the nutrient sciences as well. So that is one of the distinctions that we focus on here at Brighton. So while a lot of good evidence-based approaches work in clinical practice for many patients, there are also patients that we also know of, if you read the research and trials, that outpatient services are not working. They're not improving or stabilizing the patient. And certainly that would be many of the patients that we see in an inpatient residential kind of treatment service. And so many come to us needing really high level cognitive assessment and really working on treatment plans so that successful outpatient care through time really is where a lot of recovery happens. In other words, a lot of certainly the recovery work that happens is in the community, not in hospital-based settings. So some of the things that we're doing is really moving towards that longitudinal model that is focused on cognition. In the research kind of coined by Dr. Bob DuPont, he called programs that use this kind of model new paradigm kinds of programs, which really are foundationally built on some of the learnings that have come since the 70s in the physician health programs and some of the cognition science that comes out of those programs. But certainly our continued connection program, where we follow people not for weeks or months, but designed for bare minimum of 1 year and beyond, really looking to have a multi-year model. And we have some people in 2 years and beyond in our model. That is where our care coordinators are connecting with people on a weekly basis. So I'm just going to key in on the cognition science again. How many things are put onto patients that when they're extremely fragile, that you have to do X, you have to do Y, have you called your sponsor? New paradigm as it is kind of set up has much more of a going to patients, connecting with patients, helping fix problems, helping navigate systems, and really meeting people's needs through time as that brain has an opportunity to heal. And so by providing those kinds of care coordination services, and family therapy services that help repair family systems, cognition improvements through nutritional assessment and replacement of needed nutrients, as well as social and biological monitoring through time, we're certainly seeing very good results and outcomes in this type of treatment through time. So one of the things that certainly we're very happy about and how it impacts the lives of our patients is that looking at our 30-day readmission rates compared to other treatment programs like ours, we've been able to reduce the readmission rate by 50% compared to other treatment models and approaches. And so this is something that we're still refining. We still want to scale. We still want to get to as many people as possible. But certainly this type of care, which has been hemmed into very narrow segments of the population, including physicians, pilots, and sobriety courts, really needs to have much broader access. So what we're trying to do is offer that access to as many people as possible in that cognition healing kind of model. So some of the things that we're doing there on our campus at Brighton, at the Ascension, Michigan level, certainly there are multiple strategies that we're using as a healthcare system to really improve the lives and healthcare of our patients. So the first that has already been implemented is really a multimodal order set in management of pain designed to reduce unnecessary opioid exposure, and in every place where it has been implemented drives significant reduction in unnecessary opioid exposure while still maintaining good pain score and good pain management. So on the prevention side of the ledger, that's going to help decrease the load of unnecessary opioids going into our communities in each of the communities that we serve. Our Ascension medical group, which comprises 4 regions and 4 zones in Michigan with hundreds of thousands of lives under management, certainly is also working with a multimodal pain approach and in concert with our state legislation to really, again, reduce unnecessary opioid exposure at that level. And finally, we are working on both ER and acute care consultations for buprenorphine induction. So we have multiple sites that are already doing buprenorphine induction from the emergency room level, but also doing some that are in the acute care consultation kind of level. That was a question I know that was there. So certainly there are approaches that we are doing and designing to scale that up. And we're excited. I know this has been primarily focused on the local community here, but with our operations in the Metro Detroit area, Greater Flint area, Saginaw, and in Kalamazoo, the impact that we're going to be able to have in driving on all of these types of initiatives should reduce down certainly unnecessary opioid exposure, increase access to care, and then also making sure that we have good recovery there all the way through our communities. And so part of this also is recovery coaching. I know that was mentioned, but embedding recovery coaching in our hospitals as well, in the emergency departments and beyond. Now, just a couple of words on stigma, because I know it's been the focus of what we're talking about too. So certainly education is a part of it, but certainly it's very hard to destigmatize your thinking by reading a paper or reading a book or something like this. I do want to highlight that the value and really what is so important in peer recovery coaches is having people and patients who are living lives of recovery on clinical teams, engaging with people through time is powerful. It's powerful. It's your friend, it's your coworker, it's somebody you work with. That is so powerful as far as reducing clinicians' just kind of stigma in the mind. The other thing I would just say that was said, but I just want to highlight is language. How do we use language? And certainly that's how we communicate. We communicate with words, and they're powerful, they're important, and having respect for people and all of our patients is extremely important. And then finally, there are legislative things that can be done. I also serve on the Michigan Society of Addiction Medicine, but certainly advocacy and destigmatization goes all the way up to legislative things as well. One final thought before I turn it back, and that is just encouraging everyone on the call is there's a sense in which we need to expand treatment, but part of that is we can't just treat our way out, we need to teach our way out too. That is, we need to replicate good models of care. We need to educate our coworkers. We need to educate physicians in learning and other people in learning, because we could multiply everything that we're doing by a factor of 5 or 10 and still not have enough. So thank you, Mario. Thank you for all convening us all here, and I appreciate it very much.